Hello, good afternoon, everybody. My name is Bianca Gonzalez, and I am the Bullying Prevention Program Coordinator with the Riverside Medical Clinic Charitable Foundation. Welcome to our monthly Endometriosis Support Group webinar. I'm super excited to be facilitating this today, and I'm so excited. I've been reading the chat box along with Heather, our presenter for today, and we have a lot of viewers from literally all over the world, so this is super exciting. So I just want to start off by thanking our supporters, our sponsors, the Riverside Medical Clinic and ADV. We truly appreciate the support and your continued support as well. There's also going to be a short Q&A after the presentation, so please feel free if you have any questions or comments. We will leave some time towards the end of the presentation for that, and you can go ahead and type those in on the chat box to the right-hand side. And then we will also be sharing this presentation afterwards, so I can go ahead and email it to everybody that registered today. So I would like to introduce our presenter for today, Ms. Heather Guidone. She is a board-certified patient advocate and is the program director of the Center for Endometriosis Care, an internationally recognized disease educator and advocate. She has focused on bench to beltway to bedside efforts in endometriosis education, research, policy reform, patient-centered care, health literacy, care standards, patient engagement and adherence, and much more for nearly 3 decades. She is also an individual who struggled with and ultimately overcame advanced endometriosis and infertility. I will go ahead and give it over to Heather.
Hi, everybody. I'm just floored at where everybody is coming in from. I'm watching the box on the side, and it's just amazing. We are absolutely a global family. So I want to thank everybody for coming out and pulling up to their computers and spending time this afternoon. I know it's a Thanksgiving week in the U.S., so happy Thanksgiving for those of you who are here. We are going to run a little slideshow. Bianca is going to make it full screen. There we go. And she's going to advance those for me. So I'm just going to talk a little bit today really about the basics of the disease. I know that many of you are already experts in your own right, but what I would ask is that maybe you just take some of what you learned today back to your own communities, really start advocating not just for yourself, but for others as well, so that we can kind of all take this journey together. I do need to state that neither I nor my center is affiliated with any fiscal sponsors who are associated with today's webinar. We have not received any compensation from any sponsors. We do not endorse or recommend any sponsors or their respective products. So with that said, I'll just segue into the slide deck. One of the things that I talk a lot about is how medical knowledge, clinical experience, and healthcare therapies are really ever evolving. Endometriosis itself, however, remains fundamentally mired in outdated assumptions that really lead to continual poor outcomes. Much of what is communicated about the disease, including in the scientific literature and the media, even by some endo organizations themselves, really reflects a stagnant belief system that continually confounds the diagnostic, treatment, and support processes. So it's very important to understand how to put together the pieces of the puzzle. And that really starts first with understanding the disease and knowing your options along the journey. As patients, it's really imperative that we are able to make truly informed decisions about our care in order to achieve the best outcomes for our personal situations. So we'll talk a little bit today about what the disease is, what it isn't, what approaches might be helpful either alone or as is often the case in combination with each other, because endometriosis is truly a collaborative disease. Bianca was kind enough to tell you a bit about me. I am the program director of the Center for Endometriosis Care, where I've had the privilege of working for Dr. Ken Stenero and his center for the past 15 years. Before joining the CEC, I was working in various endo education, research facilitation, and advocacy initiatives. I am a board-certified patient advocate. I have other various certifications in healthcare and research, and I serve on a number of boards and committees related to endometriosis, pelvic pain, reproductive health, and broader health issues. and I continue to collaborate on several educational and policy initiatives intended to elevate the disease. So I've spent nearly 30 years working professionally in the endometriosis space, but like all of you, or most of you, I also have intimate, up close, and personal experience with the disease, along with adenomyosis, fibroids, and infertility. I have taken the journey many of you are on now, so I hope to be able to impart a little bit of both personal and professional perspectives to kind of help broaden the discussion and possibly help someone out there to avoid the pitfalls so many of us have encountered along the way. Standard disclaimers apply. Nothing presented here today is to be considered personal medical advice. I would also like to take a moment in the interest of inclusivity to address the use of gender-specific terms in my talk. It's really important to include all individuals with endometriosis, including and especially those among us who are gender expansive or do not identify with the biological binary that is so often assumed when issues of pelvic or menstrual pain and endometriosis are discussed. I recognize that there are many of us struggling with the disease who do not identify along an essentialized category of female, so any such terms used today are meant only as a theoretical framework and are in no way intended to trivialize, equate, or otherwise limit the scope of this discussion. Also, although often associated with endometriosis, menstruation and a uterus are not required to diagnose. Next slide, please. So, with all that said, let's talk about what endometriosis is. Clinically speaking, endometriosis is a disease characterized by the presence of endometrial-like glands and stroma located in extrauterine sites. In the very simplest of terms, that means tissue somewhat resembling but not the same as the endometrium, which is the innermost lining of the uterus, is found outside the uterus and other areas of the body. Now, this is a point you'll hear me drive home again and again. If you've ever heard me talk or you've ever read any of my writings, you will know that I use the term endometrial-like as a critical distinction. When we confuse or misclassify endometriosis as simply normal endometrium that has gone rogue, so to speak, we are supporting a century-old notion that endometriosis is disease of periods which can be cured by hysterectomy. Neither of those things are true. Although they resemble one another, endometriosis and the native endometrium have countless fundamental differences. The result is the presence of tissue, or lesions as we often call them, that can cause pain, inflammation, anatomic distortion, fibrosis, organ dysfunction, in some cases infertility, and more. It is entirely possible for every aspect of an affected individual's life to be impacted by this disease, from health-related quality of life to work to school to relationships and beyond. Endometriosis is more than just killer cramps. Symptoms often occur apart from menstruation and in those who do not menstruate, and can often become chronic, as many of you and myself, I'm sure, have experienced. Although the disease most commonly affects the abdominal pelvic region, the disease can be almost anywhere in the body, including areas like the lung or the diaphragm, and even in rare places like the brain. And if you follow the CEC's Facebook page, you will see a case that we posted, not ours, of endometriosis in an eye. So it's not just a disease of the ovaries or the reproductive organs, but it can absolutely be a systemic body-wide disease. Next slide, please. So we frame endometriosis as what it really is, a systemic disease requiring a collaborative approach that must be integrated into therapeutic concepts and symptomatic presentation in order to ensure timely diagnosis, appropriate intervention, and to reduce costly, unproven tests and protocols that don't actually help. Collaborators and stakeholders from physician, allied and mental health, and other disciplines, including legislators, payers, and employers, must engage in efforts centered on patients and their caregivers. Although pain is a common hallmark, not every case is alike, and experiences are unique, just as responses to treatments will be. But what is universal are the things that all people with endometriosis want: to be seen, heard, believed, and valued as authorities on their own narratives, to have access to high-level, gold standard care and autonomy over treatments and decisions that affect their body, to have emphasis placed on relief or at least significant reduction of symptoms, not just on procreative potential, to make our own choices through truly informed consent, not based on the bias or agenda of the prescriber or practitioner, and to be treated as partners in our own care. Next slide, please. There is perhaps no disease or disorder more aligned with menstruation, so I do acknowledge that link. But that's not the whole story, and it certainly doesn't end there because, as I've said already, endometriosis isn't just painful periods. And it's important to note that some people with periods do have moderate pain with their cycles without an underlying condition, although that pain does not typically interrupt their lives. This is called primary dysmenorrhea, and it can typically be treated through various over-the-counter measures. On the other hand, as anyone here will know, debilitating menstrual cramping with endometriosis, sometimes called secondary dysmenorrhea, is very common and may be particularly prevalent in younger patients. But these symptoms do interrupt one's life. Yet at least one study has found that there is a stigma attached to painful periods, with some people still believing that the person is just simply unable to handle their menstruation. The pain is real, it is not in your head, and this is the kind of menstrual misinformation that is propagated into perpetuity, keeping our symptoms normalized and contributing to the decade or more delay in diagnosis. Endometriosis pain and symptoms do go far beyond periods and can cause a host of issues as those seen here, and I'm sure many more that some of you have experienced. Symptoms do vary, but can include organ dysfunction, GI disruption like constipation, diarrhea, nausea, bloating, vomiting, urinary disorders, just to name a few. Impaired relationships, mental and emotional distress, interruption of school or career opportunities, religious practice adherence, casual life circumstances, and social impairment are also quite frequent. The disease rarely comes alone and may also be present alongside other conditions like certain autoimmune disorders or other pelvic pain gynepathologies like fibroids, as was in my case, for example, or adenomyosis. Next slide, please. Associated pain, anatomic distortion, development of adhesions, fibrosis, bleeding into the surrounding tissues, altered inflammatory response, and much more, all common in disease presentation. And endometriosis plays a significant role on impacting, shaping, and negatively influencing a person's medical factors, physical, psychological, sexual, reproductive, interpersonal, and occupational functioning, their health literacy, their use and dependence on the medical system, and as we all know, financial considerations as well. Endometriosis does not discriminate. It can affect an individual of any background, race, or socioeconomic status. And while many people with endo do not experience the complications or comorbidities shown here, it is absolutely without question that early intervention and increased awareness of the disease is necessary for all in order to reduce the disease impact and symptomology, as well as the potential for future impairment in patients of all ages. Next slide, please. What endometriosis is not. It is not an infectious disease. You can't catch it. You can't give it to someone. It's not a disease of older white women with painful periods, as the persistent old wives' tale tell us. In actuality, nearly 70% of teens and adolescents with pelvic pain go on to later be diagnosed with endometriosis. Research also suggests the disease may be even more aggressive in younger patients with higher recurrence rates. So early intervention and proper treatment in people of all backgrounds is critical. Endometriosis also does not go away with pregnancy, after menopause, or following hysterectomy, which many of you may have been told, and it can absolutely be present in individuals who do not menstruate. And even more isolated at the far end of the spectrum, as I've already talked about, are gender diverse individuals struggling to access endometriosis diagnosis and treatment in a traditionally female-identified space. There have also been cis males with the disease. So it's really imperative to know the facts to reduce the morbidity, infertility, and progressive symptomology in all patients, even and especially when they don't fit into a preconceived box of what some people think endometriosis patients look like or should be. Next slide, please. And so we come to the million-dollar question: what causes endometriosis? And the short answer is we don't know. In fact, multiple theories are often referred to, and despite the disease being academically studied for more than a century, we're really not that much closer to illuminating the developmental pathogenetics and pathophysiology than we have been in recent decades. A detailed understanding of the molecular underpinnings of endometriosis is an absolute work in progress still. To be sure, no single answer among all the corresponding theories explains endometriosis in all patients. They remain under constant debate, although we do know it is likely related to a number of hereditary, environmental, epigenetic, and in some cases, certain menstrual characteristics and alterations. Some scientists also believe that different forms of the disease may have different origins. It's probably fair to say that it's a perfect storm of multiple factors. To touch loosely on some of the more common ones that you may have seen or heard about, we'll start with Sampson's theory. I think everyone has heard of this, the nearly 100-year-old idea that retrograde menstruation is the cause of endometriosis and leading to hysterectomy as the cure. So this is still being perpetuated in medical texts, in the media, and throughout society as the defining cause. In fact, there are various and sundry flaws with this ideology. What Sampson taught is essentially that endometriosis is normal endometrium in abnormal locations developed through abnormal backflow of periods. So in other words, instead of leaving the body, your periods back up. This is not entirely scientifically accurate because endometriosis and utopic endometrium are histologically and biochemically different on a profound level. There are also other multiple flaws. Most notably, it does not explain pathogenesis in all patients, particularly men or non-menstruators, and approximately 90% of people with periods experience backflow periods, while only 10% will develop endometriosis. Unfortunately, Sampson's theory still guides much of the treatment and research to this day, and is probably a large part of the reason as to why significant progress hasn't been made. Other more current research implicates Hox genes, stem cells, certain immunologic factors. For example, you may have found this in your own research, immunologic dysfunction, whereas a quote-unquote broken immune system plays a role in allowing lesion development. This also does not sufficiently explain the disease process to begin with, but several studies do show that certain inflammatory cytokines are increased in those with the disease, and they can create a very highly inflammatory state, which is so common in endometriosis. Dysfunction of homeobox genes or Hox genes that result in abnormal differentiation and migration of cells during embryonic formation of the female reproductive tract later give rise to endometriosis. This probably makes the most sense. There's also been some research into stem cells, which have been demonstrated to populate lesions of endometriosis even in absence of menstruation. This could also account as well as with gene dysfunction for cases of male endometriosis. Genetics, we know that there's a genetic component. Studies have shown us that there's a 7-fold risk in those with mothers or close first-hand relatives who have the disease. For example, if you have endometriosis, possibly your sister or your mother does as well. Environmental toxicants, we hear a lot about that. Pollutants can absolutely be linked to cell changes, which could in turn facilitate abnormal lesion development and an errant immune response. Epigenetics is the latest and greatest area of research. This refers to genetic control by factors other than an individual's DNA sequence. Long story short, stress, diet, behavior, toxins, and other factors that regulate gene expression may be modified through certain processes that can lead to adverse or ill health effects, including endometriosis. So these are just a few popular theories. I could probably spend about a day and a half coming up with others that have been put forth over the years. Again, it's probably really fair to say that a composite of several mechanisms is involved. Most likely, we are born with mechanisms which, when combined, trigger the disease at some point in our lives. What is clear, however, is that backwards periods showering normal endometrium everywhere is not the cause, and the disease will not be cured by taking out the uterus. Next slide, please. So we know endometriosis is not just physically toxic, but also financially toxic to the person who suffers with the disease. With an estimated 176 million sufferers, it also has a costly societal impact in terms of healthcare burden. Direct costs and those related to loss of productivity and presenteeism, including hospitalization and emergency room utilization, soar into the billions. So anyone who tells you that endometriosis is an obscure period disorder that only affects a few women is absolutely wrong. Endometriosis actually affects everyone in one way or another. Either you have the disease or you are affected by its impact. Next slide, please. But we still have to be cautious not to think about endometriosis every time someone presents with one or two symptoms. To a hammer, everything looks like a nail. So it's really important to understand endometriosis may not always be the root of the problem, or as common, it may not be responsible alone. For example, in someone like me, and probably many of you, you may have endometriosis and adenomyosis. In that case, even after quality treatment of endometriosis itself, you may still continue to have continuing pain. Many conditions do appear simultaneously or can be confused with endometriosis. So careful workups are really necessary to rule out other concerns. But it's also important that we're really cautious not to just dismiss the disease out of hand, as it does not show on many tests and can really only be confirmed surgically. Like we always say, absence of evidence is not evidence of absence, and even in the best of hands, imaging and tests may not tell the whole story. So the idea is to be really judicious and do workups that center on the patient directly. Next slide, please. So diagnosis. I know we hear a lot in the news lately about blood tests and biomarkers and empiric drug use that will diagnose endometriosis. None of that is true. Diagnosis is still surgical. Although you may have symptoms that can lead you to believe that you or someone you care about is struggling with endo, there are no biomarkers, non-invasive tests, or medications that will diagnose it. Laparoscopy is the gold standard, and non-invasive tests are still currently reserved for the research setting. Although 50 biomarkers related to endometriosis, as well as certain nerve fibers, have been studied over the past few years, none have been identified as wholly clinically useful, so it's inappropriate to rule the disease out solely on the basis of tests or imaging. There's also zero evidence, despite the growing encouragement by certain manufacturers and their consultant teams, that empiric medical therapy is diagnostic. And of course, it's really not possible to definitively triage chronic pelvic pain patients effectively based on just their history alone, because endometriosis presents with such a unique constellation of symptoms. And like I said, it's often accompanied by other pelvic pain gynepathologies. So at its very basis, laparoscopy can spare patients who have and do not have endometriosis from potentially long intervals of expensive, uncomfortable, and potentially hazardous medical treatments and repeated ineffective surgeries. So surgical intervention is requisite for an accurate diagnosis, and it also allows, most importantly, in the correct settings, for removal of the lesions to be undertaken at the time of diagnosis. And we'll talk more about this, but who does the surgery and how is critical. You want to choose someone who's highly skilled, has a high volume of endometriosis cases, and who is able to excise the lesions, not just burn the surface, and someone who has a high volume experience with complex disease. Next slide. Next slide. Thank you. We use the word excision a lot. I don't see the slide. There it is. We use the word excision a lot, but you may be wondering, what is excision? Why is it considered the gold standard? Many of you have probably undergone excision. For those of you who are not familiar with it, excision literally means cutting the lesion out completely root to tip. Other modalities like laser ablation, which is not to be confused with endometrial ablation, a uterine procedure done for heavy bleeding, only touch the surface of the lesion and they leave disease behind. Most studies in the literature discussing endometriosis surgery are actually referring to superficial approaches like laser ablation, which is very different from actual excision. And unfortunately, all surgery is often conflated as equal, as are all surgeons. And this is really not accurate. There are specialists who have dedicated their lives and practices to the quality, integrative, and multidisciplinary care of this disease. And the surgical cornerstone of that is LAPEX, or laparoscopic excision. Excision ensures that the entire lesion has been resected. Again, we're talking root to tip, and it gives the highest chance for no persistence or recurrence of disease in most settings. I did not say it is a cure, and I did not say it will prevent recurrence in all settings, but it is the best that we have as far as surgery. Laparoscopic excision is done on a minimally invasive basis, usually, again, talking laparoscopically. It is an established, safe, and feasible technique which can be extremely effective in reducing pain, improving quality of life, restoring fertility and anatomic function, and importantly, it preserves healthy organs and tissue in the majority of the patients. Excision is a method. It can be done using any tool, such as the CO2 laser, which is our preference in our center. It is not the tool that's important, and I really want to drive this home. It's not the tool that is important, but the surgeon who uses it. If someone cannot excise, they cannot excise using any tool. All surgeons are not created equal, and it's really imperative that a thorough and systematic examination by a highly skilled surgeon is done in the patient to identify and document and remove all lesions, with care taken to really not overlook extrapelvic disease as well. The skill and the case volume of the surgeon becomes even more critically important when bowel, bladder, and extrapelvic disease are involved. Next slide. So this is just an analogy here on the importance of getting the entire lesion removed. If you hit it again, it will move. Oh, maybe not. But you get the idea. When we talk about the iceberg, we shave the surface off, but the bulk of the disease is left below. So excision will really get all of the surface disease and the hidden disease. That's okay. You can advance. Yep. You can also hear a lot online, or maybe your doctor has told you, or you've read in books, or you've heard wherever, that hysterectomy is a cure for endometriosis. It has long been touted as a cure for the disease. This is based on the premise we talked about earlier, that if you remove the uterus, you stop the periods, and thus endometriosis magically disappears. But that's just simply untrue. Removal of an organ to fix a disease that is outside of that organ is a lot like cutting off your foot because you have a pain in your knee. So hysterectomy does have a place in endometriosis, and it can absolutely be helpful for many, particularly someone like me with adenomyosis or other concerns that have pain of uterine origin. But there is a risk not only of persistence or recurrence after hysterectomy, but there's also a slight risk that the disease can worsen after hysterectomy. And sometimes you may hear about endometriosis making its own estrogen. What that's referring to is the estrogen synthesizing enzyme called aromatase, which is essentially like fuel to a fire. So taking out the ovaries may also not help. Only you can decide if a hysterectomy or oophorectomy is right for you. But what's important is at the time of that surgery, you must also have the disease excised for best outcomes. Next slide. And we come to medical suppressive, always a deeply charged topic. In the time we have today, I'm not really going to go into the medication discussion, but I'm just going to quickly touch on some of the common options used for symptom management. Medications range from GnRH suppression to oral contraceptives to IUDs. It's important to understand that all medications for endometriosis only treat the symptoms, not the disease itself. This includes the relatively newly approved medication that is being touted as a game changer by some. Make sure you're asking questions about the pros and cons and expected outcomes before undergoing any therapy, whether it's medical, surgical, or otherwise. You need to have all the facts to make informed consent for yourself. In theory, the idea of medications is to create a hypoestrogenic state and quote unquote starve the lesions. Once the therapy is stopped, however, the disease is still there, so symptoms are going to recur. Meds also have no impact on infertility associated with endometriosis. Unfortunately, we have a problem in the endometriosis community in that sometimes medication is prescribed based on the provider's preference and not necessarily best evidence or what's done right by the patient. So I encourage you strongly, do your own research, check out the literature, review the independent research like that done by the ICER Foundation, which is the Institute for Clinical and Economic Review. Talk to your doctor, get a second opinion. The bottom line is you need to be informed about realistic outcomes, possible prescribing bias, the potential for side effects, and all the other pertinent information needed to give truly informed consent. And again, that's not just medication, but it's all treatment. Next slide, please. So moving on to supplements and herbal therapies. If you eat a bowl of kale every day, I'm sorry, you'll be healthy, but you will not cure your endometriosis. The same is true in the reverse. You should eat a bowl of kale every day because it's healthy. But, patients are always seeking non-invasive means of controlling their symptoms, but we have to remain vigilant that the pros, cons, risks, and benefits are understood. When we're talking about supplements and herbal preparations, these are not just innocuous substances that aren't going to interact with medications you may already be on or that they may not harm you. So you need to be very careful, take a personalized approach, consult with professional guidance before undergoing any type of regimen that involves herbs or supplements of any kind. There is no supplement approved specifically for endometriosis, and there's no robust data required for market approval. However, there actually are a couple of things. One is curcumin, which is derived from turmeric, and pycnogenol, which is a French maritime bark. They have been studied. They are exceptions to the broader rule. They have shown in the data some promise for relief when used in certain situations. However, I cannot stress enough, consult your professional advisor, your doctor, someone who does this professionally before undertaking any herbal or supplemental regimens. They need to be geared towards you personally. Next slide, please. And because we insist all of the time that endometriosis is a truly integrative disease requiring multidisciplinary approach, there are a lot of other adjuncts in the big picture which can be tried. A lot of people do find success following removal of the disease, following excision, with certain therapies. Some are more successful than others. No two experiences will be identical. Aromatherapy seems to be quite popular. Physical therapy, I want to talk about a little bit briefly. We send a lot of our patients to post-excision physical therapy. It is considered an important, if not critical, adjunct following excision because so many patients with the disease suffer from pelvic floor disorders. Only you and your doctor can decide if it's right for you, but many of our patients do benefit from it. Next slide, please. So diet, we all see online, try this diet, you'll feel better. I cured my endo through diet, etc., etc., etc. Diet is very helpful for endometriosis symptoms, and I don't want it undervalued. However, there is no endo diet per se. This is an extremely complicated road to navigate. Again, it should be personalized to each individual based on their allergies, lifestyle, cultural needs, tolerances, and so forth. There are several ways in which nutritional approaches can reduce symptoms in many cases. I would recommend getting a hold of Endometriosis, A Key to Healing Through Nutrition, or any of the other peer-reviewed endometriosis nutritional approach books that are out there. Talk to a nutritionist who has an endometriosis client base. Find what works for you, find what you need to add, what you need to eliminate. In general, we tell our patients to look towards a high antioxidant diet and avoid heavily processed foods. Talk to your nutritionist about ways to minimize bad carbs and fats, sugars, chemicals, anything that's going to cause an inflammatory response, something that can be personalized towards you. Next slide. At the end of the day, we say all the time that all treatments should always and only ever be about the individual patient, solely based on individualized conversations, which are sensitive to that patient's cultural context, her perceptions, her attitudes. Yet we also need to draw out the symptoms and issues so they can be treated in timely and effective ways. No matter which road you take on the journey after your diagnosis for treatment, collaboration is key. The importance of a truly multidisciplinary team approach cannot be undervalued. The immediate concern associated with most clinical services for endometriosis, and you may have experienced this, they are poorly organized around multiple providers who don't talk to each other. Each functions autonomously. Each focuses and functions only on their specific organ systems. So if you, for example, if you've ever been bounced from GI to GYN for bowel endometriosis, you know what I'm talking about. That results in a silo effect, which leads to a community of patients who receive attention only on individualized symptoms rather than coordinated disease management for big picture approach. Yet the same people who are in most need of coordinated care are the ones who have endometriosis. So the best and most cost-effective outcomes are achieved when professionals collaborate with patients to learn together, engage in clinical audit of outcomes together, and generate innovations to ensure progress and practice and service together. I'll review a few components of the team approach in the next slide. Thank you. Team collaboration works in every aspect of healthcare, not just endometriosis. We know this is without question. It's been validated countless times in the literature. Core studies have been done regarding patient-centered care. Organized crosstalk, this is what I drive home all of the time. Organized crosstalk and communication is exceptionally integral to the team effort. The key goals of a multidisciplinary team approach is to effect coordination and proper transition of care, lessen the cost burdens on the patient and on society, improve the accuracy of information regarding the disease, remove or at least reduce some barriers to quality treatment. And aside from the cost factors, these collaborative efforts means that endometriosis isn't necessarily being easily treated, but it's being paid attention to in a big picture way. This can improve lives, streamline care, save time and money, most of all for the patient. So what we really need to do is to put an end to fragmented care for this disease. Coordinated care cuts the time to diagnosis, increases disease awareness, empowers patients, and improves experiences and outcomes, and improves lives, which is what we want. Next slide, please. I think everyone here will agree there exists a need to further evolve towards an approach in which collaborators work independently but interact formally in order to promote, expand, and provide access to quality treatments. We also need to look towards providing robust advocacy, influencing policy development, and increasing communication among providers and team members who should have the common goal shared among them to improve their patients' lives. When we talk about using a synergistic approach, we want to include all the disciplines that range from pre-surgical imaging to other surgeons, such as a bowel, colorectal, cardiothoracic surgeon, and other care providers. We have to routinely collaborate with our colleagues from all disciplines, sometimes even plastics in our practice, to ensure that a full complement of care is being done for our patients and to facilitate all work into one surgical event, as well as ensure the continuity of care thereafter. So when we talk about building a team, we're talking about some that are very obvious to their roles, so I won't spend too much time reviewing them. But obviously at the center is the patient. The individual and their caregiver should be at the top of the team, and they should be the ones directing their care and ultimately have final say in their choices. A general physician or general care provider is often where many endometriosis patients start out, but we need to remember that data indicated that 63% of general practitioners, when surveyed, were ill at ease in the diagnosis and follow-up of their patients with endometriosis. So ideally, starting at the GP level would at least lead to a timely referral. The GP can certainly stay and should stay involved at every level, at least from a peripheral standpoint, so as to be able to help the patient manage the stages of care, or if that's not possible, at least stay informed. Nurses, so critical, especially school nurses. These are the guardians of patient care. Nurses are the best advocates we have to help guide patients' journeys and care for them. Radiology, imaging, key component of any team. As we talked about, imaging can be crucial for pre-surgical planning and helping to even monitor patients after surgery, as well as rule out other concerns. The endo specialist, we'll talk about that a little more. Gastroenterology, urology for obvious reasons. Reproductive endocrinology, psychology, pain management. I'll touch on all of those in the slides to come. And as we've talked about, nutritionists, physiotherapists, patient advocates, social workers, alternative practitioners, even health coaches cannot be undervalued, and support groups are also key. And none of this network needs to be housed under the same physical umbrella. It can be achieved through a little effort of coordinated care. Next slide, please. So just to review a few more collaborators in detail, as we talked about the endometriosis specialist, this is typically an advanced, minimally invasive gynecologic surgeon who has a dedicated focus and special skills in excision. We've talked about excision already as the surgical gold standard of a multidisciplinary approach and how it can offer relief for the long term when performed by a specialist who truly understands the disease. Benefits of surgical excision can also be extended by certain lifestyle interventions, as we talked about, nutritional approaches, pelvic floor therapy, other adaptations. Complete excision of endometriosis, including vaginal resection if needed, offers significant improvement in sexual functioning, quality of life, and pelvic pain, including those with deeply infiltrating or deeply fibrotic disease. You may have heard people talk about stage 4 deeply infiltrating disease, or DIE. Excision can help at all stages. But again, we need to be mindful of the fact that this type of surgery requires uncommon surgical skills and anatomical knowledge. And again, it's best performed in selected reference centers. Next slide, please. Reproductive endocrinology. If you're like me, you've become well-versed in infertility and use of reproductive endocrinologists. They can be key team members when infertility is an issue, whereas the surgeon would be the expert in surgical debulking and removal of disease. The RE is the expert of multiple and complex aspects of related infertility. They can offer specialized expertise on egg freezing, assisted reproductive technology, and other options when infertility persists, even after gold standard care. Planning care together with the endometriosis specialist and the RE can be critical for an individualized approach. Next slide, please. Now, I want to stress here, when we talk about psychology or psychiatry as core team partners, we are talking about legitimate support and coping tools and guidance, not mental health assessments because someone is imagining or exaggerating their pain or because they're making it up for attention. Endometriosis, without question, significantly impairs health-related quality of life across several domains: pain, sexual, psychological, social functioning, and significant correlations exist between the severity of mental shifts and endometriosis. We see this in the data all the time. There are subcomponents as well, things like painful sex and its impact on intimacy and relationships, feelings of self-worth, self-esteem, value, social functioning, and much more. So a psychologist could be a critical part of the team approach, with the aim being to validate, not dismiss, but validate, and reduce their psychological distress to promote emotional well-being. This supporting team members' input can definitely help with coping tools, guiding treatment pathways. But again, it's critical that they do not invalidate or otherwise marginalize the person's experience. Next slide, please. Pain management centers and providers. Some of you may already be attending them. The precise understanding of pain in endometriosis remains poorly understood, and really an in-depth discussion would be outside the scope of this talk. But to briefly review the role of pain management in terms of therapeutic intervention. When we talk about chronic pain, we're defining it as persistent pain, which can be either continuous or recurrent and of sufficient duration and intensity to adversely affect a patient's well-being, level of function, and quality of life. Obviously, I don't need to tell you that endometriosis certainly falls within that category. So in many cases, a pain management specialist can be an integral part of the team approach. Pain, I don't need to tell you, is very multidimensional. There is no magic bullet which will alleviate it in all patients. But through pain management, providers and individuals can work together to find a way or a combination of ways in which to manage that individual's symptoms. This may include things like exercise, medications up to and including narcotics, cognitive therapies, interventional procedures, behavioral therapy, mindfulness, exercise, if you can, and more. So pain management is a strategy for coping, not simply a strategy which involves writing a prescription and sending that patient on their way. It takes time, it's very personalized, and it's very unique for the individual. Next slide, please. And we talked already about physical therapy. As I said, PFD, or pelvic floor dysfunction, often accompanies pelvic pain. Other things that PT is good for includes interstitial cystitis, vulvodynia, pudendal neuralgia. These things can often overlap. In each, it may be the result of tension that has developed as a protective response to pain. This abnormal guarding becomes a secondary source of pain in addition to the endometriosis, which can also create a dysfunction in the nerve framework itself. So in a center like ours, we routinely work with qualified PTs across the country to serve the needs of our patients once they leave our care. Physical therapy, along with other valuable adjuncts, is really an essential component when treating persistent pain and comorbidities that often appear alongside endo. Next slide, please. Peer support. Peer supporters, professional advocates, support and education networks. These really cannot be undervalued. These are the advocates who champion the cause for others, and they help make strides toward progress. Although not typically part of the direct clinical team, these supporters do play a key role in helping patients cope, find resources, hopefully accurate information and education by which to form educated decisions about their treatments, and they can offer a sense of unity in the face of disease, which, if you were like me, found so very isolating. In the right environment, these groups and individuals can help patients feel empowered, allow interaction at their own discretion, and be a very rewarding place for those seeking like-minded others with similar or same experiences. There are others like me and my colleagues who do serve as part of clinical teams to help patients understand the disease, have roles as medical advisors, assist them with navigating the system, provide education and support. But it's really about empowering people to properly find their way through the healthcare maze. So support and education networks, whether within the professional setting or out in the lay community, should always be considered an integral part of the larger team. But caveat, choose your groups carefully, as there can be negative aspects, including misinformation, to be wary of. Next slide, please. So all of this stuff that I'm spouting off about, this whole multidisciplinary team approach, does it work? Is it worthwhile? Yes, we have been doing it. We have been treating thousands of global patients using this exact model. We believe the key to success is removing the disease, not organs, whenever possible, and treating our patients through a team approach. Our outcomes are in stark contrast to the repeat treatment picture so often seen in endometriosis. Significantly low rates of recurrence can ultimately lead to reduction in future healthcare costs, and most important of all, patient satisfaction and improvement in quality of life, which is priceless. Of course, we are not perfect, no one is, but we do have a model that by and large works to improve the quality of life and reduce healthcare burdens. This model can be adapted in every community with the right support and personnel. We are seeing it. We are seeing centers like ours crop up now all over, whereas 30 years ago, we were one of a handful. Teams work, and patients deserve and should insist on getting collaborative care along their endometriosis journey. Next slide, please. As I said, though, at the end of the day, treatments should always and ever be only about the individual patient, solely based on that individual patient's needs and conversations, which remain sensitive to their perception, their attitudes, their physical and emotional health. No matter what your treatment pathway, the most important thing physicians can do to value their patients is to value their patients' input and encourage them to take an active role in their care. That partnership can help create a plan for best management and support. Physicians and allied healthcare workers and others who are involved in endometriosis professional can also advocate for us and be active in policy decisions for their patients. We cannot affect change alone, and we need advocates from every sector working alongside us to better the status quo. But you have to listen to your patients with endometriosis in order to ensure they're getting the tailored treatments they need. Care without compassion is not patient-centered care. We must strive to address patient concerns, adjust our approaches to their specific needs, and utilize our clinical expertise to respond effectively and appropriately in a timely manner. I would say to anyone who treats patients with this disease, if you are unable or otherwise unwilling to help in a way that suits your patient's specific and unique wishes and needs, then please, when in doubt, refer them out. Next slide, please. So I know I'm running low on time, and I want to remind everybody, behind the number of 176 million individuals, behind that number of 176 million individuals with endometriosis, are real lives being disrupted and in many cases irreversibly changed. We cannot allow the status quo to continue to exist. So I would ask that everybody joins me in breaking the barriers, moving forward to increase authoritative education, correct awareness and proper training, and to validate this disease. The only way to make progress is to affect real change in the way endometriosis is viewed and cared for, both locally and globally. There are many, many educated and dedicated individuals and resources out there working very hard, doing amazing things, pushing endometriosis forward. I applaud and value those efforts so much. And I appreciate all of the stakeholders who are making a positive difference. And I want to encourage everyone to continue to come together and support like-minded collaborative efforts, work together towards increasing disease literacy through promotion and funding of quality education and research, reduce diagnostic delays by providing timely intervention at first signs, expand fundamental components of management, and achieve reduction of cost by improving access for everyone to gold standard treatments and standardize that care for everyone with endometriosis. Accept nothing less than a multidisciplinary care team-oriented approach to reduce costly, unnecessary, and ineffective care, and give the public the correct information they need to become aware of what's normal and what's not, so they can sooner self-identify and empower them to seek the best care possible. Next slide, please. We are always at a crossroad, but never more so than now, for a real opportunity to educate, illuminate, and unravel the mysteries of this disease so that the next generation doesn't need to scream to be heard, as one of our patients said. Know that we always have a choice in the type of care and standards we will accept or push back against. It is critical that you know you are the captain of your own ship, not least of which where your health and well-being are concerned. And although endometriosis may seem chronic and is chronic, and some days it seems like there's no light at the end of the tunnel, I want you to know it is not hopeless. There are many superb care teams, physicians, and advocates out there helping to advance the disease and fighting for proper care for everyone affected. Next slide, please. But the fact remains, if we want the system that continues to gaslight us fixed, as my friend Sylvia says, we must do it ourselves. So my goal today is to have you leave here knowing that we can improve outcomes, improve lives, save healthcare dollars, and elevate the endometriosis experience for many if we all work together. This disease, I learned pretty quickly, really embodies the concept of surviving, getting through it, and helping someone else when you finally make it to the other side of your new normal. I would encourage anyone with this disease or who treats someone with endometriosis or cares about someone with endometriosis, use your voices and insist on better. Be your own best advocate and then advocate for someone behind you. Last slide, please. So I know that this has been a lot to take in, and I didn't drill down on too many aspects of the disease specifically. But the idea is to let you know that this is a collaborative journey and we are on it together. So thank you. And I talked a lot, so I need to drink.
Thank you so much. That was great. So this opens up our Q&A portion for this webinar, and we already have a couple of questions. So I will go ahead and start off with the first one, written by Chris. I'm sorry if I mess up your last name, Lieb. And their question is, since endometriosis causes inflammation, can we treat it with medication for inflammation? For example, patients with RA and lupus using Plaquenil.
All I'm getting is feedback. Can you repeat that?
Are you able to hear me now? Let
No.
me lower my volume. Is it a little better now?
No.
No? Okay.
I don't know if it's just me or what, but it's just all feedback.
Unfortunately, it might.
There you go. I
Can
can hear you now.
Okay, perfect. I'm so sorry about that. So our first question was from Chris Lieb, and their question is, since endometriosis causes inflammation, can we treat it with medication for inflammation? For example, patients with RA and lupus using Plaquenil.
I mean, ostensibly that's an idea and a thought. I could probably pull the literature and find a few therapies that they've tried, but nothing has been effective in terms of, yes, we can reduce the inflammation through certain medical suppression, even the ones on the market now, but there hasn't been anything that actually treats the disease. I think there may be a few things on the horizon that we should be looking for, but right now, no. Sorry. Good point.
And then we have another question from Nancy. It may or may not have been covered in the presentation, but she'd like to know, what can one do if over-the-counter painkillers no longer help daily chronic pain, and hot water bottle providing no relief, just scars?
Yeah, that's a story that lots of us know. You know, unfortunately, there's no single or easy answer. when you have reached the end of your limits with things that are available to you, it's time to go to plan B, whether that's finding a new doctor, trying a new therapy, surgery may be warranted and indicated. I think that as patients with endometriosis, you have a right to a second, third, fourth, and fifth opinion. And if the self-medication isn't helping and the things that are available to you right here and now are not helping, it's time to explore other options. That may mean a prescription medication, that may mean prescription drug suppression, that may mean pain management, that may mean surgical intervention. It really just depends. But I think that you seek other options and other opinions to form the next idea as to what to try.
Thank you. We have another question from Jenny, and she would like to know, will having monthly menstrual cycles after an excision surgery cause the disease to come back?
Two parts answer here. First, following excision, those first couple of periods can be tragic. I just don't know how else to explain it. They can be exquisitely painful. And the reason for that is because you're really dealing with now what is a clean surface, for lack of a better description. So it may be inflamed, it may be painful, you may have cramps, you may have all of those things. And we have a lot of people that say, oh my God, I had excision, I had my first 2 periods, is the disease back? Not necessarily. In terms of having regular periods thereafter, just going forward, some folks believe maybe a course of continuous oral contraceptive after excision for pelvic rest might be helpful. There's really 2 schools of thought on that. One school believes you absolutely must suppress, preferably with GnRH analogs. The other school of thought thinks you don't necessarily have to suppress, because if you've removed the disease, ostensibly it should not be coming back. Now, of course, realistically speaking, we do know that even in the best of hands, the disease may come back. The chances are much, much lower, but it does happen. So I don't think there's much harm in thinking about or discussing possibly a short-term course of oral contraceptives, maybe, if you feel you need them. If you're not having pain at, month 3 or 4 and everything seems fine, you may not need them. But if you're going on month 3, 4, 5, 6 and you're continually having cramping, you need to investigate why. Is there another pelvic pain generator? First of all, and second of all, would a sort of innocuous course of oral contraceptives be helpful?
Thank you. We have a couple more good questions. One that from Melissa is, can deep infiltrating endometriosis cause chronic mesenteric lymphadenitis? If I said that correct or incorrect, I apologize.
Say it again. Cause what?
Chronic mesenteric lymphadenitis or lymphadenitis. Not too sure if I said that correctly.
Let me scroll up and see if I can find. Is the question at the top?
It'll be in the open questions portion, and it's from one of our viewers. Her name is Melissa. I'm not too sure if you can scroll down on the portion, and then you can see our open questions that we have.
Oh, here it is. Okay, chronic mesenteric lymphadenitis. That is not my understanding. Deeply infiltrating or deeply fibrotic endometriosis can cause a whole lot of things. I would think that if that were the case, it would be the result of a secondary process, not the disease itself. When we talk about DFE or DIE, typically the things we worry about are bowel obstruction, silent kidney loss, and again, this is not common, but it does need to be talked about. Severe ongoing chronic pain that is intractable. I would definitely talk more probably to my endo specialist about that and maybe get some referrals for other opinions.
Thank you. So we are coming towards the end of the time for this webinar. We have a lot of great questions for you, Heather. But if you would like, I can go ahead and just refer them to your email address that's listed, because we do have more than 6 questions. So I'm pretty sure they would still like to speak to you further about.
Yeah, that's absolutely fine, because I know I went way over with my slides, as I always do when I talk.
It's great
But yeah, no,
information.
anyway, my email address is right there. You can email me. In terms of the pelvic floor physical therapy question, two-part answer there. Clear Passages is a company that does massage therapy, breaks down adhesions. They have talked about their success rates with infertility through their therapies. I would look them up. Clear Passages. Pelvic floor therapy is a form of physical therapy done by a highly skilled, specifically and specially trained physical therapist who practices only in women's health. They can go in and work the muscles near the rectovaginal septum, the lower abdomen, throughout the pelvis. Again, like most things associated with endo, it is a specialty. You can find a skilled women's health PT by going to apta.org. That's apta.org. I would also reach out to Dr. Sally Sorrell, who runs the Endometriosis Summit, and she can possibly help or refer you.
Thank you. I just want to go ahead and finish by thanking everybody today for viewing our webinar from wherever you are in the world. We have literally such a diverse endo family viewing today, as well as Heather for this amazing webinar. We truly appreciate the information. It was super informational and just beneficial for all of us viewing it today. Thank you so much.
Thank you, everybody. Happy Thanksgiving.
Happy Thanksgiving. Bye-bye.
Bye-bye.